We're going to finish up the antibacterials with TB. And then next week we do fungals, virals, HIV, and then you don't want to miss the next Friday, worms and parasites. It's always fun. You've got worms. All right. So TB is a unique organism, or TB is a unique infection caused by a unique organism. So the class of bacteria that cause tuberculosis is called mycobacteria. This is the genus of acid-fast bacteria. What does acid-fast mean? Acid-fast means that when we do a gram stain and we wash with acid to get rid of the first stain, these don't wash properly. So the acid doesn't do anything. So they don't stain like normal gram-positive or gram-negative organisms. The cell wall of these bacteria is what is different about them, and the cell wall is why they don't stain like they normally would. If you look at the cell wall of these organisms, these mycobacteria, what you see is a plasma membrane down here at the bottom and a peptidoglycan layer above it. So this is reminiscent of the gram-positive organisms, right? There is no second membrane above the peptidoglycan like the gram-negatives, right? So they are more gram-positive-like in their membrane peptidoglycan, but they're kind of gram-negative-like in that there is a layer of a protein called a arabinogalactan, and then above that we see is this thick layer of mycolic acid. And this is really what distinguishes these organisms and why they're called mycobacteria, is that this thick layer of mycolic acids, these are about 60 to 90 carbon atom containing almost fatty acids. So very long chain mycolic acids. And this is really what distinguishes these organisms. This is what makes them have extremely hydrophobic cell membranes. And this hydrophobic cell membrane serves as a very strong barrier to permeability. So a very strong barrier to permeability. And this is why this class of organism is really resistant to the other antibacterials. I mean, the targets would be sensitive. For example, peptidoglycan, well, you could use a cell wall inhibitor, right? If the drug could permeate this thick layer, which it can't. So the beta-lactams really don't do anything because they can't get down here, permeate through this mycolic acid to get down here into the peptidoglycan layer. Okay? Now, these do have small hydrophilic channels similar to the porin channels that we've discussed. So these small hydrophilic channels are similar to the porin channels. I have some data here. The number of these channels leads to 100 to 1,000-fold less. So essentially there's 100 to 1,000-fold less numbers of these channels compared to like an E. coli, which has abundant porins. So 100 to 1,000-fold lower number of these small hydrophilic channels in these mycobacteria compared to like an E. coli, which has abundant porin channels. And so this is why some of our hydrophilic drugs can permeate, okay, because there are a few of these channels. And so some of the hydrophilic drugs that we talked about that can specifically permeate mycobacterium and can be used for TB were what? Okay, streptomycin. So the class of aminoglycosides, several of those were good at TB. Why? Because they can access these few, but still there, hydrophilic channels and gain access to the inside of the cell through that route. If a drug is lipophilic enough, it can permeate these mycolic acids to some degree. And an example of drugs that we've talked about that were lipophilic enough to do so would be what? You guys remember from yesterday? fluoroquinolones. So some of the fluoroquinolones can maybe, moxifloxacin, for example, can maybe penetrate these based on the fact that they're lipophilic enough. But for the most part, outside of the fluoroquinolones and the aminoglycosides, we're not going to be able to permeate this mycolic acid layer in order to get to killing this bacteria. So we have to have a whole new class of drugs. Mycobacteria tuberculosis, tuberculosis is the specific mycobacterial species that causes tuberculosis. There are two other species, actually three other species. Mycobacterium avium complex, MAC, is one that we talked about. And this includes the two species shown here, avium and intracellulare. Okay, so the complex is caused by these two. We'll talk about this in a second. And then Mycobacterium leprae causes leprosy. And so these all belong to the class of Mycobacterium, the genus Mycobacterium. These are going to be small rod-like bacilli, and they withstand the effects of disinfectants. Okay, so they withstand the effects of normal disinfectants and can stay alive in the dry state. For example, on a counter or a hospital surface or similar. So they can live in the dry state longer than your normal bacteria would be able to. Right? So if you spit up some E. coli on this counter here, it'll stay alive for a little bit. Someone can come by, touch it, and it'll stick to them, and then they touch their hand or their eye, and an infection will spread. So an E. coli will stay alive on a surface for a little bit. But if it stays on that surface indefinitely, at some point it's going to run out of nutrients and it's going to die. These organisms can withstand being in that dry state without media, without nutrients, for a much longer period of time. And the reason behind that is because they are very slow dividers. Okay, so they replicate very slowly compared to any other bacteria. The doubling time here is about 24 hours. And that's very slow for a bacteria. You put an E. coli in culture, and it's going to double every 30 minutes or so for a period of time. Okay? So much, much faster for other bugs, whereas this is a very slow divider. You guys have heard of the lag phase and the log phase, right? So the log phase of growth for an E. coli is very quick, minutes, whereas log phase here is on the order of days. Okay? Inside of cells, they can grow. So this is one of the challenges of treating TB, is that in vivo, they can grow inside those host cells. So these are some of those intracellular bacteria that I brought up yesterday. And again, I want you to keep this in mind here. This is kind of the big deal. This is why these are difficult to treat due to this mycolic acid layer. The arabinogalactans are essentially attached to the mycolic acid layer, so they keep the mycolic acid layer in place, if you will. And so you get these attached to the peptidoglycans, and this whole system kind of stays in place by attaching to each other. So we're going to talk about these mycolic acids in depth. There's one drug that affects arabinogalactans, so we'll talk about that drug as well. So these will be drug targets. All right, let's talk quickly about the specific diseases, the three specific diseases. Leprosy is the first one I'll start with. References to leprosy can be found throughout history. In the Bible, there's many references to history in other religions, holy books. You can also find references to leprosy. So leprosy back then, a few thousand years ago, was thought to be a disorder of cleanliness. So these people were thought to be unclean people. Okay, and if you're a religious person reading these texts, they were thought to be sinners. Okay, and that's why they got these diseases. There's about 20 million people worldwide, mainly in the tropics, that are infected with leprosy. So this is not a disease of 2,000, 3,000 years ago. This still happens today. Does have a long incubation period of about 3 to 5 years. So many children are affected, but they don't have the symptoms, and so they'll grow up without knowing that they have this disease, and then all of a sudden it sets in. So the person-to-person contact is the mechanism for spread, and so a child that doesn't know they have the disease is going to spread the disease without knowing it, and so this is kind of the problem. Okay. Leprosy will affect the skin and the peripheral nerves wherever the site of infection is. Usually you start seeing changes in the skin color, followed by periods of, lack of a better term, anesthetic. So tingling followed by numbness is what happens. Over time, the muscles will atrophy. You get resorption of the bones and essentially spontaneous amputation, which is what you see in this hand here. Okay, so it's a very disfiguring disease. Marissa?
Garrett and I worked at the same Walgreens a couple of weekends here.
Okay.
And it was in Knoxville, and we had a person that had it.
Interesting. Wow.
She didn't have insurance. I can't remember what drug it was, but it was real.
Yeah.
We
Yeah.
didn't know what she had.
Yeah.
So we just called the doctor to switch it.
Uh-huh.
And he was like, I'm going to have to call the CDC. This is the first case of leprosy
Yeah.
I've ever seen.
Yeah. So here's a case of leprosy in Knoxville.
Yeah, we didn't know what to do to help her because it was
Right.
so expensive, and he didn't know what to switch it
Yeah.
to. And it was,
Yeah. And so this is an interesting story because we don't see too much leprosy
yeah,
here.
we were like shocked.
Yeah,
We were
and
like,
so
"Oh."
here's a case of a physician that didn't know how to treat it, and so correctly call CDC, and because these are the experts at treating these type of diseases because they consult worldwide. But I'd be interested to find out how this diagnosis occurred. Was it due to amputate? I mean, did they figure it out? Okay, she didn't look disfigured. Interesting.
He like confirmed it when we called.
Yeah.
I'll have to get back with you. We'll see if there's something we can do.
Yeah.
I don't remember what ended up happening, but
Very interesting. Interesting story.
when I called, I was like, I'm done.
Yeah, yeah. And so this is uncommon to have a case here in the United States, but not so uncommon if you've traveled outside the United States, particularly the tropics where this is really endemic, right? And so people travel, they come back, it's spread person to person, so they can come back with it. Mm-hmm. Mm-hmm. Right. Yeah. So Alex, right? Alex says her mom grew up in South Florida. Interestingly, South Florida is there's a lot, particularly in Miami, a lot of these tropical diseases that we typically don't see in the United States, but they happen because of travel. Miami is kind of a point of entry for the Caribbean, Central America, South America. So a lot of these diseases, like TB, for example, tuberculosis, Miami is going to be one of the hot spots, similar to New York. Why? Because people that come from Europe are going to come into New York, and they typically choose to reside there initially anyways. And so there's a lot of this kind of hot localization of these type of diseases. Interesting. Very cool. Anything else? All right. So I'm not going to spend a whole lot of time on it because we don't see a whole lot of it here. MAC is the second one. Again, this is the complex of really two bacteria that kind of, for lack of a better term, live with each other. So the Mycobacterium avium and the Intracellular coexist typically with each other. And so this is going to be two separate bacteria in these patients. This is ubiquitous in the environment and non-pathogenic and healthy. There's Mycobacterium avium in this room probably. Okay, so for those people that have a normal immune system, no problem at all. We breathe it in. All of us have breathed it in at one time or another in our lives, and it poses no risk at all. The lungs are the primary target, but it can disseminate to these other tissues. The problem with this is the most common bacterial opportunistic infection in HIV/AIDS. Okay? So the problem occurs when a patient has an immune system that is compromised, and we really didn't know anything about this disease until HIV came up. So when these people have immune system compromised, then all of a sudden this normal, ubiquitous disease that is not really a disease, but these normal, ubiquitous bacteria can pose a problem. Okay? This is going to be the third most common opportunistic infection in AIDS. So it's the most common bacterial opportunistic infection, but the third most common opportunistic, the first being Candida albicans, which is going to cause some very nasty yeast infections. So we're not talking about topical yeast infections, okay, like thrush. Thrush is a topical yeast infection of the mucosa. We're not talking about vaginal yeast infections. We're not talking about diaper rash. We're talking about now serious disseminated yeast infections in organs that can affect organ systems. Pneumocystis jirovecii. I want you to make this change on your slides. It's not correct. And in fact, this was on the sulfonamide slide too, where sulfamethoxazole trimethoprim was noted to cover pneumocystis carinii. The name for pneumocystis carinii has now been changed to pneumocystis jirovecii. Don't ask me why. It's a long, complex, drawn-out situation. But what we used to call pneumocystis carinii, I won't care to go into why this has changed. Some of it is political. Is now called jirovecii. It's the same organism. So anytime you see pneumocystis carinii, people are talking about pneumocystis jirovecii. It's the same organism. They're just calling it by the old name. So you may want to correct that person and tell them that the new name is jirovecii. Okay? Well, this is a point where, if someone was trained a number of years ago, they're going to be calling it that way unless they see it frequently and they're aware of the name change. All right. So my focus today is going to be, we will talk about MAC today too, with some of the drugs that cover TB will also cover MAC. But my focus is going to be on Mycobacterium tuberculosis. Okay? This is going to cause the disease tuberculosis. That's easy enough to remember. It's a chronic infection. This species, Mycobacterium tuberculosis, has the highest degree of lipophilicity within the cell wall, so it has the highest concentration of those mycolic acids of the 4 Mycobacterium species. So it's, again, going to be resistant to alcohol, to acid, to base, to disinfectants, so on and so forth. It's estimated that up to a half of the global population is infected with this bacteria. And I'm going to show you some epidemiological stuff that will really show that this is a worldwide, a global problem. Okay? 6% of all worldwide deaths are due to tuberculosis. The U.S. incidence of this disease has increased since 1991. Overall, the overall rate has fallen. Okay? The overall rate of transmission in the country has fallen, but the incidences has actually been going up. This is a lot of this is due to homelessness. Immigration is a big one, and I'll show you some of the epidemiology that shows how foreign-born folks like me affect the rate of TB. Drug abuse due to the needles. Prisons due to the easy spread and the close contact of prisoners, as well as the AIDS epidemic. We now have a multi-drug resistant TB. We'll talk about what that is. This has a 50% fatality rate. So 50% of the people with MDR-TB will die. So TB itself is going to be transmitted primarily by the respiratory route. These, as I cough, I say that. These bugs, as I'll show you, will be engulfed in the alveoli by macrophages, and those macrophages then can carry the bug to other parts of the body. Okay, so it's actually the macrophages that disseminate TB from pulmonary to extrapulmonary sites, and I'll show you that in a minute. The symptoms are going to include fever, weight loss. The very distinguishing symptom is a chronic and productive cough with blood-tinged sputum. Okay, so this is a chronic cough, can last for months, and it is a productive cough. So you guys know the difference between a productive cough and a non-productive cough. Productive cough will have sputum typically in it. Non-productive is just kind of that hacking, dry cough. Okay? Not every patient that has this disease will develop, let me rephrase, not every patient that has the bacteria will develop the full-blown disease. Okay? So not every patient that has it will progress to having an active tuberculosis infection. And in fact, the numbers are pretty low. 9 out of 10 people just carry this thing around. Okay? 1 in 10 of these latent infections, 1 in 10 of these latent, meaning kind of dormant infections, will progress to an active tuberculosis disease. And again, if this is untreated, it can be fatal. Does that make sense? So 9 out of 10 people carry it. Could be asymptomatic, not even know it. Okay? In 1 out of those 10, it will lead to a productive, to a active disease. The disease is transmitted by droplets after sneezing, coughing, or talking. Okay? So a typical sneeze has anywhere up to 400,000 droplets. That's a lot. Okay? So in one sneeze, there could be a lot of TB being passed around. It can be, who am I talking to? Jenny? So it can be passed if that patient is not active. So if they're a carrier, those 9 out of 10 carriers cough, they can transmit the bug. Good question. Thanks for bringing that up. Okay. All right. The TB skin test, which you guys all have to come to school here on an annual basis, checks for the presence of the local TB antibody. Okay, so this skin test is checking for that person if they have any antibodies against tuberculin, okay, which is the antigen that the TB organism expresses. So tuberculin is an antigen. When we do the TB skin test, we're going to be checking for an antibody that your body has made against that antigen. I'll talk more about this in a minute. Okay? So let's talk about the disease here real quick again. It's a pulmonary infection in 85% of the cases. So this is in the lungs only. Okay? This is the primary tuberculosis disease. Okay, so Jenny, look at this. Infectious dose can be as little as 10 bacterial cells. Okay? So 10 cells coughed on someone or sneezed on someone that is a carrier, from a carrier to someone that doesn't have it, as little as 10 cells can cause the infection. These bacteria are going to primarily reside inside the alveoli of the lungs, particularly in the macrophages, which are constantly skimming the alveoli. Okay? So the macrophages are constantly in that alveolar milieu, and these bacteria can reside in them. It can be asymptomatic or symptomatic with a fever, as I already mentioned. And here we get slight formation of bacterial tubercules. Tubercules here, what I mean by this is clumping up of the bacteria to form what is called a tubercule. These are essentially bacteria-laden macrophages. So they clump up inside these macrophages and form kind of macromolecular granulomas. So a mass of cells that's laden with these bacteria. And what's interesting about these tubercules is that they can be detected by X-ray. Okay? So when we do a chest X-ray for TB, that's really what they're looking for, is this mass of bacteria which reside in these granulomas, which are made of macrophages that are just full of them. Okay? Some of the bacteria, as you'll see, will escape from the lungs into the lymph or the blood. This disease can be eventually recovered from, or can progress to a secondary disease. And the secondary diseases on this slide, these bacteria can remain dormant and reactivate in a period of time. That time could be weeks, months, years. And if they're reactivated, then they can spread, essentially. This is especially important in those that are immunocompromised. In those with normal immune systems, TB is almost exclusively in the lungs. Okay? So those people that have normal immune systems typically are going to get TB that's pulmonary. People that have immune compromise typically get disseminated TB that's spread from the lungs into other tissue. Okay, so in secondary disease, many of these tuberculoses are formed and they expand into the upper respiratory tract. This can lead to a more violent cough, more bloody sputum, and some of the symptoms shown here, chest pain being one of them. All of these symptoms here, including the cough, because this is a violent cough now. This person is doing more than just hacking a few times a day. It's just a chronic, constant coughing. The fever, the anorexia. What does anorexia mean? They're not eating. They have no appetite, no care to eat. Fatigue, sweats, leads to wasting of the body, and this has been referred to as consumption. And so some of you may have heard this term, consumption, referring to TB. Back in the old days, it was called consumption because the bug essentially consumed the body. Okay, so you may have heard back in the old days TB referred to as consumption. Lack of treatment of secondary disease has a very high mortality rate, 60%. All right, again, let's talk about this extrapulmonary TB. Most common in immunosuppressed or young children. The effects of extrapulmonary TB mainly reside within lymph nodes, kidneys, the longer bones, genital tract, brain, and the meninges. This represents a very high load of the bacteria within these tissues. And so you can see any of these tissues are going to be affected, can or will be affected. So renal TB can cause necrosis of the kidney. That's not a good thing. It can cause scarring of the bladder and the ureters, accompanied by painful urination, blood in the urine. So those aren't good things. Genital TB in males can damage the prostate, the epididymis, the testes, and the seminal vesicles. So genital TB in males can essentially damage the entire male reproductive tract. In females, fallopian tubes, ovaries, and uterus are damaged. TB, if it affects the bones, can cause very complicated and painful effects, mainly in the spine, the hip, and the knees. And so these things don't work properly. So you need your spine to do something as simple as getting up out of bed. And that becomes very painful. Walking becomes very painful if the knee is affected. So you kind of get the point here. TB in the brain can cause anything from retardation. If it's in a younger person, it's going to cause mental retardation, blindness, deafness, and if it's untreated, it will eventually be fatal. So you can see that a lot of different things can happen if TB is allowed to disseminate from the lungs into the other parts of the body. All right, the overall number of cases over the last 10 years or so of TB have gone down a little bit, but you can see here in the U.S. we had a good peak that was rising up until about the mid-90s, and this increase was directly related to the HIV epidemic. Okay. about 1995 or so, the rate started dropping in the U.S. This is directly related to the use of protease inhibitors for treatment of HIV. And we'll talk about that next week. But you can see that the rate now holds steady. Okay? And what I'll show you is that this rate is really directly proportional to foreign-born people now. So the increase rate, if there's any increase in the U.S., it's from foreign-born people and not necessarily spread from person to person of people that live here. Meanwhile, the global incidence of TB has been steadily rising. I only have data from 2006 here from World Health Organization. But there are presumed to now be well over, today in 2013, well over 6 million cases worldwide. So the global incidence has gone up a lot. HIV, again, has a lot to do with this. If you look at the estimated TB incidence rates, this is 2010 data. The lighter green have the lowest rate per 100,000 people. The darkest green have the highest rates per 100,000 people. So you can see the greatest density is in sub-Saharan Africa, okay, as well as over here in Southeast Asia. Okay. And so the people that are traveling from these areas in particular, people that travel to and from, if they're coming back, to these areas, sub-Saharan Africa and then Southeast Asia, are at the highest risk for getting TB, and they're at the highest risk for bringing TB back with them unknown to them. Unknown to them. Okay? So really, all of sub-Saharan Africa, so the Sahara is somewhere around here, right? So everything underneath that is at very high density, and then everything from Iran, which is where I'm from, to over to yeah, you too. From Iran over to really the end of the world there is at high risk. Okay. So this should start clicking now that okay, we have pretty low incidence, but now people that come to the United States, especially from these countries, have a high risk of bringing it with them. Okay? Now, many of these countries vaccinate against TB, so if someone here was born in one of these countries, they may have been vaccinated against TB. In Iran, back in the day, I was born there. I only lived there for 5 years before we moved. I happened to be vaccinated against TB for that reason. Okay? So when people come from these countries, they can be vaccinated, and depending on what country, they may very well be vaccinated. And that plays an important role, which we'll talk about in a minute, with the PPD test. All right, so the number of TB cases in U.S.-born versus foreign-born persons in the United States. And I don't want to focus too much on this epidemiology. I don't really want you to spend a whole lot of time on these graphs. Kind of big picture is what I'm interested in, okay? So now look at U.S.-born in white, foreign-born in this purple color. So the U.S.-born cases in white, very high in the mid-90s. Again, mainly due to HIV. Protease inhibitors came about somewhere in mid-90s. So you see that incidence has steadily been decreasing. The foreign-born incidence has been steady. Okay? So pretty steady. So now the majority, again in 2010 is the latest data I could find, the majority of cases are now foreign-born cases here. So the foreign-born population higher. This slide provides a little bit of insight on the total number of U.S. TB cases the past few years. This is per 100,000 people. The TB rate here, as you can see, the last few years has been going down actually. Okay, so it's been going down the last few years, but not significantly. I mean, we're pretty much 4 to 5%. TB case rates. Let's look at this. Alex brought up this geography in South Florida. So if we look at the TB case rates in the United States, the highest prevalence of this is going to be California, Nevada, Arizona, Texas, Miami, Florida, Georgia. Okay? And then some of those states, I don't know, can you guys see this? I can see it on my screen, but not much contrast on the board. Where is it? Why is it not there? That's weird. You got it, Victoria? That's very weird. Yeah, you guys see that, right? So the big point of this is these states are, with the exception of Alaska, You from Alaska? Oh. Oh, sure. With the exception of Alaska, these states have the highest foreign-born populations. Okay, so it's again correlated. Okay, so foreign-born population, they have this disease, may not even know it, and then they immigrate, and there you go. Okay. Yeah, what's up with Alaska? Good question. I don't know about the epidemiology there. But again, Hawaii, if you look at the population of Hawaii, and particularly travel from Southeast Asia to Hawaii, you'll find very high incidence of travel from people from Japan, from people from Southeast Asia, the other countries in Southeast Asia. So that's one of the reasons Hawaii is on the list. All right, if you look at age group, you'll see again, the incidence per 100,000 overall has been going down for many of these people, but the highest incidence now is in those older than 65. Okay, this epidemiologically is going to be simply based on the fact that the older you are, the longer you could have been exposed to, or the greater chance you could have been exposed to this bacteria. Okay, so age is really, it's easy to tell. The younger you are, the lower chance of being exposed. As you live longer, you get a greater chance of being exposed. So age is really easy to see. Again, this slide here by race and ethnicity. So the lower risk here is in Caucasians, and then as you increase from, let's see, what are we doing here? American Indian or Alaska Native is the next. Black or African American is kind of in line with the Hispanic or Latino population. And then at the top here, the Asian population. Again, why? Because of the endemic nature in Southeast Asia and the population of Southeast Asia. There's more people there per square foot. Okay, so there is a risk associated with, again, where you're coming from. And this slide just shows you the change within the last decade in the percentage of TB cases among foreign-born persons in the United States. I'm not going to focus on that anymore. So what I've tried to show you from all that epidemiology is that the incidence of TB is directly correlated to what part of the earth this person lives in. In the U.S., still, we have pretty low overall compared to globally incidence of TB. Okay. Tuberculosis is definitively defined by the presence of the bacteria in cultured sputum or other fluid like the CSF. So the signs and symptoms lead the physician to suspect tuberculosis, but the definitive diagnosis does not come from even a PPD test under your skin, but by the presence of the bacteria in the sputum. Okay? So you can see here, this is culture of the sputum, and you can see the presence of the bacteria in there. This is not a gram stain. These bugs, as I show you on the next slide, these are going to again be acid-fast, so there's a specific acid-fast bacillus stain that is used, and this is typically a fluorescent stain. So these contain fluorochromic stains. And so you're not going to get a good gram stain using the gram stain or the counter stain with these bugs. Okay? The definitive diagnosis can also be done by chest x-ray. The upper lungs will almost always be affected, and the presence of the tubercules can be noted. You can see this white material here. I don't know if you guys have had any experience looking at x-rays, probably not so much, but this white material here, all of this white here is indicative of the tubercules. So the lungs should be clear. It should look like this. Okay, it should look like this pretty much. There should be nothing there, and you start seeing white, the presence of all this white, and that is the tubercules that you can visualize on an X-ray. All right, TB will lead to a huge immune response, and so the people that have TB have a very powerful antibody synthesizing reaction that's occurring inside their bodies. So the PPD test is really a marker of that immune response. And what they do is essentially in the PPD test, and you guys have all had this, right? You still have to have it? Yeah. Every year? Yeah. So essentially they come under the skin and they inject the PPD tuberculin antigen. This is not the bacteria at all. It's not going to make anyone sick. It's not going to lead to the infection. The PPD test is only designed to help diagnose those that have been infected. Okay? So it essentially involves injecting a small amount of that tuberculin antigen that is derived from the bacteria. There's no live bacteria. It cannot cause disease. And essentially what happens there is that when that tuberculin is injected into the dermis, it's antigenic, and so it will attract antibodies that patient's body has made against the tuberculosis bacteria. Now again, TB leads to a huge immune response. Almost every type of imaginable immune cell takes part in the response to the presence of tuberculosis. So if you have tuberculosis, then macrophages, neutrophils, T cells, B cells, natural killer cells, almost every type of immune cell takes part in responding to the bacteria. So if this person has had TB, they have had antibodies. They have antibodies floating around in their bodies, and that antibody response is going to cause swelling at the site of injection. Swelling at the site of injection. If the person has not ever had TB, they will not ever have antibodies developed, right? And so that person will not get swelling. Simple as that. So you go in after 48 hours or so, and they check to see if you have swelling. If you do not have swelling, then you have never made antibodies against the tuberculosis bug, and so you're said to be free of the infection, right? If you have had a bump form, and it depends on what category the person is in, and I'll tell you about the differences in categories in a second, but different sizes of bumps can be positive depending on what category you fall in. Okay? So a small bump may be normal, but a large bump always signifies the presence of the antibodies. Does it mean that that person has an active TB infection? No. It means that this person has, at some point in their lives, made antibodies against TB. The two most important categories here are, one, HIV. If a person is HIV positive, a very small bump is indicative of a positive test. Okay, category 1, very small bump, HIV, indicative of a positive test. Category 2 is a little bit larger bump, and if it's in the size of 10 to 14 millimeters, this person is positive if they come from one of the high-risk countries that we've talked about. Okay, so if you're coming from one of the high-risk countries, Sub-Saharan Africa or Southeast Asia, then they won't consider you positive unless your bump is a little bit bigger. Why? You could have been exposed to it, but never have really gotten it, but you could have been exposed to it and your body made antibodies because it's so endemic in those populations. Okay? And greater than 15 millimeters positive in Category 3. Category 3 is really neither of the first two. So if someone's living in the U.S., low-risk country, and does not have HIV, then a larger bump is what's considered normal. Now, those with a past positive test, or those people that have been vaccinated against tuberculosis, like myself. As I mentioned, in Iran, where I was born, I lived there for 5 years. I probably got a couple TB vaccines during that time. So anyone who has had a past positive test or anyone that has been vaccinated against the tuberculosis bug will have created antibodies and will test positive for PPD all the time. Okay? Anyone ever been vaccinated in this room? Yeah, a couple of you. Good. Okay. So you guys, if you go in, you probably get a bump, right? Right? I don't know what category you'd fall in. You'd get a bump. Okay? It's probably kind of in the middle here. Okay? Why? Because your body has made antibodies against this. So for those people, the test is not going to be worth anything. Typically, they send you to have a chest x-ray done. Yeah. So typically, they'll want to see a chest x-ray to make sure that, that your lungs are clear and there's no white spots. Linda? I didn't hear you. How come the skin test? Oh, okay, so how come this antigen being put in here doesn't create the antibody to be produced? That's a great question. So it takes more than just this one antigen to get that immune reaction. Okay? And that's exactly why they use the tuberculin, so that it doesn't sensitize you. Okay? So there are multiple antigens that are involved in the immune response to the actual presence of the bug. And this is only one of them. Okay? Yeah?
When you treat it, does it mean that the immune system is on to eradicate it?
Okay, so when...
Still continue to be a carrier?
Yeah, this is a great question, kind of ahead of where I want to be. The question is Olia, right? Olia's question is, when you treat TB, is the bug completely eradicated or does it come back? So this is very difficult to treat. Typically, it's going to take multiple drugs, multiple treatments to eradicate it, and then you may have thought you've eradicated, but then it comes back. Okay, so it could be a recurrent infection. In some people, it is completely eradicated. Okay, the problem is we can't be certain because we can't test for it. You know, you can do chest X-rays to make sure the lungs are clear, but if it's somewhere else, then it can come back. So.
What about if you tested positive, not because of the vaccination?
Okay.
Because you have antibodies. Does
Okay.
that mean that you are a carrier?
Yeah, so if you've tested positive and you've never been vaccinated, if you've tested positive on the PPD test and you've never been vaccinated, then all that means is your body has made antibodies to the bug at some point. It doesn't necessarily mean you're a carrier. It doesn't necessarily mean you have an active infection. You're going to have to do a chest x-ray to tell that. Okay? If the chest x-ray is positive, then you have the bug. If the chest x-ray is negative, then at some point you have made antibodies, but you may have never had an infection. Okay?
So you're not a carrier.
You don't necessarily have to be a carrier. No. Yeah. Yeah, so the x-ray will tell you if there is any type of active infection in the lung. Okay? If there's no active infection and you're a carrier, the x-ray is not going to tell you anything. Okay? So this is just looking at active infection in the lung. All right, let's take a break till the top of the hour.